Hello everyone, and thank you all for being here. My name is Michel Coppieters, and I've been asked to reflect in the next 15 minutes or so on the validity of upper limb neurodynamic tests. I've organized this talk in two components. In the first part, we will discuss whether neurodynamic tests are actually biologically plausible tests for the nervous system, and in the second part, we will reflect on the concurrent validity or diagnostic accuracy of neurodynamic tests. And I promise that I won't bore you more than needed with concepts such as sensitivity and specificity and likelihood ratios. But rather than doing that, I would like to take one step back and reflect on some of the decisions that were made in these diagnostic accuracy studies that largely influenced the calculated values or the reported values of sensitivity and specificity. Because if you look at the literature, the findings are contradicting. Some of the earlier work suggests that neurodynamic tests are great tests to rule out the presence of a neuropathy, and that these tests are not good tests to rule in a neuropathy. On the other hand, there's more recent work that actually shows that these tests are good tests to help ruling in a neuropathy. So as I said, rather than jumping too quickly to these values of sensitivity and specificity, we'll take a step back and we need to understand some of the design of these diagnostic accuracy studies and some of the decisions that were made so we know which findings are more trustworthy than others. But first things first, let's focus on mechanosensitivity and whether neurodynamic tests mechanically load the nervous system. This is a fairly old study now from 2005 from Andrew Dilly and colleagues, but still worthwhile mentioning, I believe. What the authors did in this study was that they created a local inflammation in the sciatic nerve in rats. And the authors observed then that if they applied minimal stretch or minimal compression of that inflamed region, that ectopic impulses, ectopic action potentials, were generated from that affected area. So the authors concluded that if a nerve is affected, that part of the nerve becomes extremely sensitive to mechanical loading. Now, we do have too many studies to mention that provide evidence that the individual components of neurodynamic tests indeed mechanically challenge the nervous system. It can be through longitudinal or transverse excursion, it can be through strain or tension or compression. So we have plenty of evidence that from a biomechanical point of view, neurodynamic tests are biologically plausible tests. On the other hand, we also know that the different neurodynamic tests for the upper limb share various movement components. For example, shoulder abduction, elbow extension, wrist extension, or cervical contralateral flexion are components that occur in multiple tests. We also know from a biomechanical point of view that neurodynamic tests cannot selectively load a nerve root, for example, or a spinal nerve. The question, however, is, can it be done in the axilla or further distally? And that was exactly what was examined in this study. The aim of this study was to determine the position of the arm that resulted in the greatest amount of tension in the targeted nerve, and in this study that was the radial nerve. In this study it was the ulnar nerve. And the second aim was to determine the position that resulted in the greatest difference in tension between the targeted nerve and the other two major nerves in the upper limb. For example, in this study, the ulnar nerve versus the median and the radial nerve. And in the interest of time, I need to simplify their findings a little bit, but overall their findings were that the neurodynamic test positions and the routinely recommended sensitizing maneuvers were those positions that met these two criteria. So these two studies also demonstrate that from a biomechanical point of view, neurodynamic tests are biologically plausible. So we have plenty of evidence regarding the mechanosensitivity of the nervous system and mechanical loading of neurodynamic tests. But especially in the last 10-15 years or so, our understanding of nerve pathology following nerve compression has increased significantly. And we do know that it's much more than just increased mechanosensitivity. For example, Nina Schmidt in her PhD demonstrated that when a nerve is compressed, there's not only a local inflammation at the entrapment site, but there are also neuroimmune responses much more proximally. For example, at a dorsal ganglion and in a dorsal horn. And we also know from animal studies and clinical studies that in an entraperneuropathy, not only the myelinated large fibers are affected, but also the small diameter nerve fibers. And with small diameter nerve fibers, we mean the A delta and the C fibers that are typically not evaluated in nerve conduction studies. And from clinical studies, we do know that this small diameter nerve fiber pathology might actually take place earlier than your large fiber nerve damage. And of course, these pathomechanisms of entraperneuropathies do not necessarily translate one-to-one to increased mechanosensitivity. And that is exactly how more recent findings are interpreted. This study here, for example, by Larissa Baselgia demonstrated that only half of the people with carpal tunnel syndrome actually had a positive neurodynamic test. And it was shown that those people with a negative neurodynamic test had actually more severe small fiber nerve damage. And then finally, of course, when we perform neurodynamic tests, we evaluate tissues in people, and people have biological, psychological, and social components to their clinical presentation. And of course, these are things that we need to take into consideration when deciding on the relevance of neurodynamic test findings, but also when trying to identify the dominant pathobiological mechanism in operation, for example. But these considerations are similar for neurodynamic tests and other clinical tests, so discussing this in detail is beyond the scope of this presentation. What I would like to do next is reflect on the concurrent validity of neurodynamic tests. And I'm sure that the majority of you are familiar with the design of diagnostic accuracy studies. On the one hand, we have the reference test, or the gold standard, and the outcome on this test will determine whether the patient does or does not have the disease. On the other hand, we have the index test, in this case the neurodynamic test, and we compare the results of the reference test with the results of the index test. If there's agreement, the results from the neurodynamic test are either considered to be true positive or true negative. If there's disagreement between the reference test and the index test, the outcomes of the neurodynamic test are considered false positive or false negative. Once the 2x2 table is completed, it's then easy to calculate the sensitivity, specificity, predictive values, and likelihood ratios for example, in this case, the neurodynamic test. Now, as I said earlier, rather than just jumping to these values and concluding whether they have a high or low sensitivity or specificity, I think it's good to reflect on the factors that may influence these diagnostic accuracy values. For example, we need to reflect on the characteristics of the so-called gold standard for neuropathies. We also need to think about the criteria for a positive neurodynamic test. When is it positive? When is it negative? And I would like to start with these criteria for a positive neurodynamic test. Weiner, in his study in 2003, considered a neurodynamic test to be positive if there was either a reproduction of symptoms, or if the symptoms changed with structural differentiation, or if there was a left-right difference in range of motion of 10 degrees or more. So as long as a patient met one of these three criteria, the test was considered positive. These criteria were then applied to a group of patients who were suspected of having cervical radiculopathy or carpal tunnel syndrome. And if we look at the results, we can see that with these criteria, the specificity of the neurodynamic test is very low, 0.22. Of course, this is due to a large amount of false positive tests. Now, if you think about the straight leg raising for a moment in the lower limb, can you then see that with these criteria, if a patient has an arthritic hip and a limitation in range of motion, that a neurodynamic test with these criteria might be positive, although there is no neuropathy. Or if I think about a patient with a hamstrings tear, a straight leg raising might reproduce the patient's symptoms. Using these criteria, the patient would score positive on the neurodynamic test, although there is no underlying neuropathy. So that's why I say these criteria are fairly lenient. Yeah, it's very easy to score positive, maybe too easy to score positive on a neurodynamic test. So the specificity with these criteria is low. Now, if you look at the formula for sensitivity, you will notice that the number of false positives is not considered. Also, if it's very easy to score positive on a test, the ones that are negative are probably true negative. Yeah, so there will be very few false negative results. This means that the sensitivity is most likely to be very high, and that's exactly what Weiner and colleagues found. And they found a sensitivity of 0.97, near perfect. Now we all know the acronym SNOUT. If a test has a very high sensitivity, when the test in your patient is negative, it's good to rule out the presence of the disorder. And based on this study, there became a bit of a generalized belief that you often read in book chapters as well, or even in review papers, that neurodynamic tests are good tests to rule out the presence of disorders and not to rule them in. But of course, this is only if you apply these very lenient, and I would say too lenient conditions, considering the examples I gave for the straight leg raising. Okay, let's now look at a different study that applied different criteria. In the Appleby-Albrecht study, a patient had a positive neurodynamic test if there was a reproduction of symptoms and a change in symptoms with structural differentiation or the application of sensitizing maneuvers, and if there was a left-right difference in pain production. And patients had to meet all three criteria before the test was considered positive. So not just one, but all three. And if these stricter criteria are applied to patients who are suspected of having neck and arm pain, we can then see when we look at the results that the sensitivity values are still fairly high, with the exception for the findings of the radial nerve in this study. But we also see that the specificity values are much higher than the 0.22 that was reported by Weiner. And we see that the specificity values range from roughly 0.7 to 0.8 in this study. But there are, of course, also other differences in these two studies. For example, with respect to the reference test or the gold standard. Weiner used nerve conduction studies as part of the gold standard, whereas in the Appleby-Albrecht study, medical imaging or MRI was used as part of the reference standards. And of course, some of the differences in diagnostic accuracy values might also relate to the reference test, but I'll come back to that later. The following study is useful to look at the impact of different criteria for a positive neurodynamic test on diagnostic accuracy values. And what the authors did in this study is that they used the same sample of patients suspected of having carpal tunnel syndrome, they used the same reference test, but then they applied different sets of criteria and looked at how the diagnostic accuracy values changed. So first of all, a neurodynamic test was considered positive if it produced any symptoms or if it reproduced the patient's symptoms and if these symptoms changed with structural differentiation. Now, if we look at the bottom at the results, at the likelihood ratios, we have to conclude that they are fairly mediocre. You'll remember that a positive likelihood ratio has to be larger than 2 to help rule in a disease, and a negative likelihood ratio has to be smaller than 0.5 to help rule out a disease. So not very useful. Now, if we apply stricter criteria, then we see that the likelihood ratios improve. So if a neurodynamic test is only considered positive if the patient's symptoms are reproduced, and if these symptoms change with structural differentiation, we see, for example, that the positive likelihood ratio is now larger than 2. And so it becomes a useful test to help rule in a disease, as opposed to some of the early conclusions with very lenient or too lenient criteria where the test was useful to rule out the disorder. If we look at the negative likelihood ratio, we see now that it's bordering on being a useful test, 0.5, to help rule out a disease. Now, it's probably useful to mention that the criteria in the previous study that were associated with a positive neurodynamic test and that resulted in clinically useful likelihood ratios are those criteria that we previously recommended for a positive neurodynamic test. A neurodynamic test can only be considered positive if there's at least partial reproduction of symptoms and if these symptoms can either be increased or decreased with structural differentiation. Now, I would like to emphasize the importance of reproduction of the patient's symptoms. In the earlier work about the validity of neurodynamic tests, tests were often performed in healthy participants. Now, a lot of these studies report high incidences of false positive neurodynamic tests. Now, if we stick to the criteria of reproduction of the patient's symptoms, that criterion can never be met in healthy people, right? Healthy people, obviously, during a neurodynamic test will often have a bit of a stretchy feeling or even pins and needles, for example, during the test, but this is not a reproduction of their symptoms. Healthy people have no symptoms. Yeah, so the high incidences of false positive tests in healthy people are simply incorrect. Then lastly, a few things about the characteristics of the so-called gold standard or the reference test. It's important to realize that there is no perfect reference standard for any neuropathy, whether it's carpal tunnel syndrome or cervical radiculopathy or cubital tunnel syndrome. Nerve conduction studies, quantitative sensory testing, imaging, clinical tests, just like neurodynamic tests, are not 100% accurate. And that's important to realize, so we do not have a perfect reference standard. Another important thing to realize is that there is a discrepancy between the domain of the reference test and the domain of the index test. What I mean with that is, as I said previously, the domain of the neurodynamic test is testing for increased mechanosensitivity. The domain of nerve conduction studies or quantitative sensory tests is nerve function. The domain of imaging is structure. And so we have different domains. Now, of course, ideally, we would like to see that the reference test and the index test are from the same domain. Or if they are from a different domain, that these domains largely overlap. Now, with neurodynamic tests and some of the reference tests, there's likely to be quite a discrepancy between these two different domains. There is some overlap, but there's also not necessarily a full or complete overlap. And that is nicely demonstrated by that first study I started my presentation with. I already highlighted that when a nerve is inflamed, the nerve becomes extremely sensitive to mechanical loading. However, the authors also demonstrated that there was near normal nerve conduction velocity through the inflamed region. And so nearly normal nerve conduction velocity. So normal nerve conduction studies. Two different domains. So these are a few considerations we need to take into consideration when thinking about concurrent validity studies and values that are reported in the literature. So in summary, a research-informed view. So considering the context of compression neuropathies, and with context I mean that there is no complete understanding yet of the pathophysiology of entrapment neuropathies. That we do not have a perfect reference standard for neuropathies, and that the reference standard is often of a different domain than neurodynamic tests. That there might be more and different mechanisms involved than we previously believed. Think about neuroimmune responses, both local and remote. Think about large and small nerve fiber involvement, etc. Think about positive and negative signs in patients with neuropathies. And then it might well be that in patients who have the same label, who have the same diagnosis, for example, carpal tunnel syndrome, that there are very different dominant mechanisms in operation. Same diagnosis, different mechanisms. So if this is the context, it wouldn't be smart to expect that one test in isolation, whether it's a neurodynamic test or any other clinical test, would be or could be the test for that certain condition. Yet this is how we typically design our concurrent validity studies. We take a reference test that may consist of imaging, nerve conduction, clinical tests, etc. and we typically compare that with, for example, a neurodynamic test. However, bearing in mind this context, I believe that neurodynamic tests probably do have merit as one element in a comprehensive diagnostic process in patients suspected of having a compression neuropathy. It probably helps though when that neurodynamic test is performed with great skill, as accurately as possible, and also interpreted, as I previously explained, according to sound clinical criteria. Thank you very much for listening. I hope you found it a useful short presentation. Thank you.